Chapter 18 covers cardiac emergencies. As a bit of a view of the cardiovascular system, overall the flow of the blood through the chambers of the heart, going from the atriums to the ventricles, to the pulmonary system, back into the atria and the ventricle, then through the circulatory system. The cardiac conductive system, the whole heart beats on an electrical system, just like your vehicle operates on electrical current from the battery. The heart needs its own type of electrical current to effectively contract those muscles of the heart to create the cardiac circulation. After there's composition of the blood, the cardiovascular system will develop its own compensatory mechanisms by speeding up the heart rate, everything trying to keep that cardiac output up the same, but if they remain too hypotensive, the body can only compensate so much, or if there's limited blood flow, the vessels can only restrict so much. There's only so many compensatory mechanisms the body can do. As the blood flows, goes through the arteries, down to arterioles, through everything, through the capillaries, to the venules, back to the veins. So going from larger vessels down to smaller vessels at the capillary, and then back through smaller vessels back into larger vessels before re-entering the heart. The right ventricle ejects blood out of the right ventricle into the pulmonary arteries, into the pulmonary system for gas exchange and oxygenation, back into the pulmonary veins where the left atria receives its oxygenated blood. Seeing that diagram, refresher. Blood comes in from the inferior vena cava from below, from the superior vena cava at the same time, and those two dump into the right atrium. From the right atrium, blood flows through the tricuspid valve. Try it before you buy it. Going into the right ventricle. Right ventricle squeezes, pumps through the pulmonary arteries into the lungs. From the lungs back into the pulmonary veins, into the left atria through the bicuspid valve, left ventricle, big muscular squeeze here, sends it out through the aorta to the rest of the body. Acute coronary syndrome, ACS, is basically a blanket term for any time there is a new onset heart condition, something that's not a chronic event. That's why it's called acute coronary syndrome, not because it's pretty, just because it's not a chronic condition. So there's different kinds of problems under this ACS title. Basically, anytime there's a heart condition of the heart not getting enough oxygen, it's acute coronary syndrome. Symptoms of acute coronary syndrome. The classic one, chest pain. Whether it's that crushing, dull, a heavy pressure, a squeezing, sharp stabbing, whatever it may be, but that chest pain, the most common type of symptom you'll see with ACS. Now, chest pain may radiate along the arms, down into the abdomen, up into the neck, and into the jaw. It varies. Every person is different, so just because they're having chest pain and no pain to the jaw or along the arms doesn't mean they're not having an acute coronary attack. Also, they may have anxiety or that impending feeling of doom. I've had patients having heart attacks and they're completely anxious, just saying that something's wrong, I feel like I'm dying, I really think I'm going to die, and they're having a massive heart attack. Also, it can be nausea and pain, or nausea because of the pain, or just generalized nausea and discomfort along the epigastric area, that upper abdomen area, right about the lower part of the ribs, right below the xiphoid process. Additional symptoms include that sudden onset of sweating, diaphoresis, abnormal vitals. They can have a dysrhythmia, a weird change in their heart rate, whether it's fast or it's slow, changes in blood pressure, high or low, just a wide array of things. A lot of the patients will also have dyspnea, difficulty in breathing, and with some of them, that may be the only finding in those patients. Now, really old patients, say 70s, 80s, 90s, a lot of them are going to present different. The older populations feel pain differently. So That 98-year-old woman at the nursing home may just feel a little weird sensation. It feels like she has indigestion, and she could be having a massive heart attack. Also, diabetics, you may have heard like diabetic nerve pain, but diabetes can mess with your nerve sensation, so those patients may not feel nearly as much pain as the normal semi-healthy person does who may be having a cardiac event. A lot of the symptoms do mimic non-cardiac conditions such as indigestion, acid reflux, just the patient who's burping and doesn't know why. So anybody who could present with acute coronary symptoms that anything it could be related to cardiac, treat them as though they are having a cardiac event. Treat worst case scenario. Typical assessment when dealing with the cardiac patients: doing the primary assessment, their ABCs, checking their pulses, the circulation on every single patient you come up to immediately, getting a good history, a valid physical exam, and use an OPQRST sample, all the mnemonics together, all their information along with their history and the vital signs. Patient care: first and foremost, make them comfortable, provide ventilatory support if need be, or just simply oxygenate. For shorter breath, give them an on breather, maintaining that oxygen between 94 and 99%, and never delay transport. Also, obtain a 12-lead ECG to help. You can transmit that to hospitals or medical command, and that can help differentiate between which hospital you may need to go to, whether you may be okay to go to the local closest hospital because nothing's showing up that they may be having a heart attack, or it could come up and say that they are having a major cardiac event in that 12-lead and you need to take them to a higher care facility because they may need cardiac interventions. With a 12-lead, you have your normal right arm, left leg leads, and then you also, that's your normal 4-lead, then this turns it into the 12-lead. So you have your V1 and V2, they go around the fourth intercostal space, right about the nipple line. Next, you'll put on V4. V4 is midclavicular, next rib below. So that'll go just directly generally below that nipple, midclavicular line. Then you'll put V3 just directly in a straight line between V2 and V4. Then along the side, V5, V6. So it's often easier after you've put V1, V2, V4, V3 to put V6 as its mid-axillary line, and the V5 just fits right in between 4 and 6. So first step in that patient having chest pains, giving them aspirin, or for the first intervention, give them aspirin, 324 milligrams of that chewable aspirin. Only contraindications really, if the patient has a true allergy to it. Now if their stomach gets upset because they take aspirin, that's not a contraindication. But a true allergy to where they could go into anaphylaxis. And some places will have protocols saying if they have a history of asthma, not to give aspirin. Aspirin can exacerbate asthmatic conditions, but most of the time, don't really know of anybody who's giving aspirin to a patient with a history of asthma who has any kind of issues with it. Also, be cautious in those asthmatic patients or any patient who's taking blood thinner medications. But really, true contraindications is a true allergy, and to make sure the patient doesn't have any kind of active bleeding or like GI bleeding, gum bleeding, those kind of things. Next step is nitroglycerin. First thing you need to do is make sure that their vitals are within normal limits, at good blood pressure, and anymore the medical command operators want to see a 12-lead before they'll allow you to give nitroglycerin. In certain types of heart attacks, not all heart attacks are equal, but certain types of heart attacks, depending where it's at in the heart, if you give them nitro, it can make their blood pressure plummet immediately. So with some patients having chest pain and having a true heart attack, they don't get nitro. They get skipped straight to narcotics. So most of the time you're doing that 12-lead first, obtaining the vitals, making sure they got a good blood pressure, Depending on protocols, generally systolic pressure above 90, most typically it's a blood pressure above 100, and making sure they haven't had any erectile dysfunction pills within the last 48 to 72 hours, depending on which medication it is. And then once you have all that information, you relay it to medical command. They'll give you the authorization to give the nitroglycerin. After you give it, after 5 minutes, you repeat your assessment before you repeat the dose. So you'll repeat the dose as long as the vitals are still good, that systolic blood pressure is still good, and medical direction said that you could give more than one dose, and if they're still in pain. So if you've taken them to a complete zero of pain, you don't have to give all 3 doses. So the goal is get that pain management or get that pain in kind of control. Now, as nitro is not a pain medication, it just reduces that workload of the heart and that preload pounding back into the heart who may have essentially damaged tissues. So now we'll talk about causes of cardiac conditions. They can be caused by multiple things, just any kind of thing that can damage the blood vessels or anything damaging the heart. Coronary artery disease, basically as it says, the arteries of the heart end up becoming narrowed or blocked due to fatty deposits built up on those inner walls of those arteries. So you have a normal sized vessel and a lot of plaque and gunk built up inside of it. It makes the vessel smaller and restricts blood flow to the heart. Reduced blood flow means that those muscles of the heart aren't going to be getting that blood supply that they need, resulting in that chest pain or later on into a complete actual heart attack. So as the picture shows, a normal artery, nice size orifice of the artery and a good ability for the blood to flow. Coronary artery disease, the vessel is essentially the same size, just a lot of plaque buildup. So the inside of that vessel becomes a lot smaller. It's going to limit the blood flow. So limiting blood flow to the muscles of the heart can cause that infarction, causing parts of that tissue to die. Big underlying things: smoking, high blood pressure, high cholesterol, diabetes, or just a really poor lifestyle. Just dirty, don't brush your teeth, never clean, don't eat well, those kind of things. A thrombus is also part of coronary artery disease. Basically, it's a formation of a large clot on the surface of that artery. So that thrombus can break off. So those big plaque buildups can be a thrombus, just basically a big mound of gunk inside that vessel. Well, that thrombus can break off and end up becoming an emboli. That emboli circulates through those larger vessels and can get stuck once they reach those smaller vessels. So what happens with that? You've got large vessels in the body. Say there's a large vessel in your leg and it's got a bunch of plaque buildup in it. This emboli breaks off of it, circulates through the body, and once it finds a smaller vessel, can get stuck and just completely shut off all the blood flow. So that vessel could be in your heart, in your brain, in your lungs, anywhere. An aneurysm is a weakened section of an artery wall. So you've probably all seen those garden hoses that get dry rotted, and up by the nozzle there's a huge lump in it. And every once in a while, or eventually, that lump's going to get a pinhole. So every time you're trying to use that water hose, water's squirting out of that large lump in the side of a hose. The aneurysm is the same exact way with those vessels. That outer wall of the artery will give away, and then the blood that's supposed to be in that will seep out into that kind of balloon on the side of the artery. That could stay there and they can live like that, or it could eventually bust. So it's basically just the whole vessel exploding, causing life-threatening internal bleeding. As you see the diagram, get that large lump in that vessel. As it stays under pressure, conditions of smoking, high blood pressure, high cholesterol can cause that vessel to get weak. So it'll stretch out, stretch out, stretch out, and eventually it can just give away, rupture. And you imagine the larger the vessel it is, the more blood they're going to lose. So large arteries that have this just going to dump a whole lot of blood inside the body. Massive, massive internal bleeding that's generally very fatal. There can be electrical malfunctions of the heart resulting in a dysrhythmia. Now, a dysrhythmia, think about medical terminology, is dyspnea, is problems breathing. Dysrhythmia is a problem with the rhythm. This can mean that the heart rate's speeding up, slowing down, or that the rhythm they are in is lethal. So a lot of times when those patients die, it's not because every patient has a heart attack. They can just develop a dysrhythmia, a weird heart rhythm that just makes them die. Some terms with that: angina pectoris. You'll hear patients talk about having angina because that's what the physicians say. Angina is pain. Pectoris, your pectoral muscles. Chest pain is angina pectoris. Acute myocardial infarction, AMI or an MI, you'll hear it used in both ways. That is a heart attack. That infarction, that's an occlusion of those coronary vessels that stop or reduce the blood flow to the heart, causing that infarction of the muscle tissues within the heart. And congestive heart failure. So angina pectoris is just chest pain caused by that reduced blood flow to the myocardium, or the myocardium being the tissue of the heart. Typically it's those narrowed arteries from coronary artery disease, a plaque buildup, things like that. This is generally caused by the person who just overexerted themselves. The old person's got poor health, trying to walk up too many flights of stairs, suddenly becomes symptomatic of having chest pains, difficulty in breathing, things like that. Acute myocardial infarction, death of the myocardial tissue. Underlying reason: coronary artery disease caused by the even more underlying diseases of high blood pressure, diabetes, high cholesterol, smoking, just poor health decisions. So in the diagram, you could have this vessel right here that has an infarction of the heart here. So this vessel supposed to be wrapping all the way down here, but it has a clot right here, and then now there's no blood flow to this part of the heart, so it will die. So as a cross section here, you could see that this big hunk of the muscle just dies, so it won't have an ability to squeeze anymore. Same kind of analogy when your arm goes to sleep, there's poor circulation going to that muscle and it's hard to do it. So imagine you wake up in the morning and your arm's asleep because you slept on it weird. You wake up, you can't move it until blood flow starts to get back to it. So in this part of the heart, there's been no blood flow, so that part of the muscle is not going to squeeze again. And this could potentially be forever, that part of the heart may not squeeze again. So if it's a large enough part, that's going to result in death. Congestive heart failure is that inadequate pumping of the heart. So that could be caused by the MI or severe hypertension, bad leaky heart valves, pulmonary diseases, different things. This generally often leads up to fluid accumulation in the lungs or extremities. So pedal edema, pulmonary edema. So the example, that old lady working a cashier's line just goes real slow, not a lot of stuff happening, so everything starts to back up. That is the poor pumping of the heart. So everything will start to back up because the squeezing of the heart, the pumping of it can't keep up with the demand that it needs to. Same thing, the old lady. She can't keep up with the demand of Black Friday shoppers. So the progression of congestive heart failure. A lot of times that patient has an MI. So that left part of the left ventricle dies, the big squeezer of the heart. So because the damage to that left ventricle, blood's going to start to back up into the pulmonary circulation, causing that pulmonary edema. If that goes untreated, undiagnosed, and that left side of the heart's getting messed up, and the right side's having to work harder, trying to do work of the left side, it can eventually fail too, resulting in complete heart failure. The signs and symptoms of congestive heart failure: tachycardia, they're having to work hard to breathe, move blood. So dyspnea, cyanosis, because there's poor oxygenation because the lungs could be full of fluid. Normal elevated blood pressure, most of the time with this you're going to see the opposite of that, the elevated blood pressure, really high blood pressure. I've had blood pressure cuffs, actually the Velcro come completely undone because their blood pressure's too high. Squeeze it up, can still hear a pulse when it gets up to about 280, and the Velcro starts to fill in the cuff before it gets completely inflated. So a patient with that kind of blood pressure in a condition for all kinds of badness. Then the diaphoresis, just because there's not good circulation going on, the skin's not getting what it needs, the body's in shock. Along with that, having anxiety and confusion due to hypoxia, even pedal edema or edema in any of the extremities around the abdomen, that JVD, those engorged neck veins, and that is a late sign. Another late sign is that enlarged liver or spleen, just from poor circulation and all the organs and everything else having to make up for the failure of the heart. The worst case scenario, cardiac arrest. Their heart stopped, they are dead. So the chain of survival, the big elements that go into good CPR and the life-saving it goes into cardiac arrest. First, immediate recognition and activation, meaning you readily assess that yes, they are dead. Quick determination of that. And then activation, meaning calling for extra help, getting all the help you need into play, and even calling 911, calling for more backup. Then beginning CPR early and getting that defibrillation in as soon as possible, and advanced life support. So the quicker you can start CPR, the better the chances are. You can defibrillate faster, chances get even better. You add advanced life support, that's the ultimate. And then if you do get them back, that good integrated post-cardiac arrest care. And all that, the big component is good teamwork and coordination of said team. For high-performing, high-quality CPR, you're compressing about 100 to 120 times a minute. Remember that fast tempo of another one bites the dust or another one stays alive is good, hard, fast chest compressions. With an advanced airway in place, you're ventilating every 6 seconds with continual chest compressions. You never interrupt CPR for any more than 10 seconds, whether if that's you're having to ventilate, try to move a patient, whatever you got to do, limit those interruptions of chest compressions. Putting those hands in the lower half of the breastbone, just above the xiphoid process, proper hand placement. So lower half of the breastbone, generally just below the nipple line, and that's where the nipples are supposed to be, so not where they may currently be. So don't do chest compressions on grandma's hip. The sooner you can defibrillate the patient, the better. So as soon as you have access to whether an AED or a monitor, you need to get that on, hooked up, so it could analyze, do its job, so you can defibrillate as soon as you can. So the assessments of ABCs in your normal medical patient, checking the CAB if they're unresponsive, then tying into the cardiac arrest of the CMAs, not the Country Music Awards, but doing those compressions, monitor, and then get the airway going. So get those compressions going, and then defibrillation, and then get the airway going. But get that defibrillator hooked up as soon as you can. So as review, contraindications for the AED is if those pads won't go into proper alignment without touching one another. If the patient's hypothermic, if you find someone who's dead out in the snow, you can't defibrillate, or they can't get medications until they're warmer. You can't be going to shocking frozen or super wet patients. If the patient's touching anything metallic, anything that conduct that electricity that somebody else may be touching, don't shock them. The story of at a WVU game, when the patient went into cardiac arrest, everything went great according to the plan, monitor hooked up, alright, I'm clear, you're clear, everybody's clear, they shock, and then half a stadium did the wave because the patient's still lying on metal bleachers, and everybody still on the metal bleachers got their butt zapped. If there's any kind of medication patches on her, say a nitro patch, fentanyl patches, any kind of patch, get that off because heat can be generated. You don't want those patches to melt or any kind of crazy other things to happen. And then be always to say clear. Make sure nobody is in the danger zone to get shocked with electricity. If all goes great and you receive that return of spontaneous circulation, ROSC, you got to maintain good oxygenation because at this point your patient's alive. They have a pulse. Avoid hyperventilation, so continue to ventilate that patient once every 6 seconds unless they can completely 100% breathe on their own, which honestly chances are limited. Get that 12 lead in place, analyzing maybe what has caused them to die and to get them to the closest appropriate facility. Need to use capnography. If you have them hooked up, you've got the advanced airway place, you're bagging them, you put the inline capnography. If you see that it's slow, say less than 10, that means you need to push harder, do more adequate CPR, and ensure, one, that there's not an inclusion somewhere in there that the numbers are just skewed. If all of a sudden it's high, it goes from being at 10, 12, so now suddenly it's at 80, check for ROSC, check for pulse, because 99.9% of the time, they're alive at that point. So you can look for these waveforms. If you start to see those and they're higher numbers, say in the 60s, 70s, that's meaning the patient is alive, and as you're bagging them, you'll see these waves. If you start to see peaks or plateaus outside of your bagging, that means that they're trying to breathe on their own. So the normal range we're looking at is 35 to 45 millimeters of mercury. So as the patient obtains resuscitation and it's peaked up, it'll eventually come down a little bit. So as you ventilate them, this is a range you're wanting to be in. So if you need to come down with it, you bag a little faster. If you need the numbers to come up, you bag just a little bit slower. A witness arrest in ambulance, this is your best chance of resuscitation, that good close witness arrest. If you do need to get the AED and everything hooked up, when it's analyzing, the AED cannot analyze properly while the ambulance is on the move. So stop the vehicle, let the monitor analyze. If it says no treatment advised, drive for another 2 minutes until it's time to analyze again. What you see here is the Lucas 2 device. You just see there's a hard board that goes under the torso of the patient, and then the two arms reach down, they clamp in, and in the video it does take them just a little bit to get the patient adjusted to the proper placement to where the plunger will get centered the same place you do hand compressions, over the lower half part of the breastbone. You take the plunger, center it where you need to, and then on the top you hit the start button and it continues to do automatic compressions, whether you have it set to do continual compressions or you can set it to do the 30 chest compressions and 2 ventilations. When it comes to do ventilations, if you set it at that, it will alert you to provide those ventilations. Once you do begin CPR, you have to continue until you either receive resuscitation, you've turned the care over to personnel of higher training, or you receive a no resuscitation or a stop efforts order from a physician, or you have additional authority depending on what the protocols are. One such reason to discontinue resuscitation efforts or to not even actually initiate them is proof of an advance directive, or also known as a do not resuscitate order, a DNR. What this is a legal document of limitations of care you may provide. This means that the patient has a paper that has been signed by the patient, by a physician, saying that if a crisis happens with them and they are not able to answer what their desires are, this paper is a legal document saying what you may or may not do to them treatment-wise. So this may say on there that they do not wish to be resuscitated, and with that, you must follow it. Different local protocols may vary as to whether family can override this, so just always consult with medical command on any time you have to stop CPR or you're not going to initiate CPR. An example of that advanced directive, as you can see on here, some of these are titled "The Physician's Orders for Life-Sustaining Treatment." This is an example of one from California, but it is very, very, very similar to the ones in West Virginia. It says on here whether they want or do not want CPR, and if they do, what the types of interventions that they do request that you do. Sometimes they'll just say, do not resuscitate, don't do anything if you find me dead. Others may say, yes, you can do CPR and you can do a little bit of stuff, but really don't try too hard to bring me back. Now, discussions of a new device that's out, fairly new, in about the past probably 4 or 5 years, these kind of came about. Now they're a lot more seen than they used to be. It's called an LVAD, a left ventricular assist device. What this means is the patient's basically in complete heart failure. Their heart isn't pumping, so they have this device that circulates the blood for them. This was their last step before they have to get the heart transplant. Generally, everybody that has one of these is on a waiting list for that heart transplant. So it's a vest that they wear. It has 2 battery packs on it, and those battery packs are replaceable, rechargeable, everything. And you'll see here in this diagram, it shows a hose going into the abdomen, and it routes up inside into this device. Other people that have a hose that goes in the side, but one way or another, you'll see a vest with some batteries, a device mounted on the side of their hip or as part of the packet, and there'll be a hose that goes into their body. What that goes into is a valve. So blood enters into the heart the same way it normally does, going to the lungs, everything as it does, but that left ventricle is pretty much dead. It's not strong enough to circulate the blood to the rest of the body. So out of the left ventricle, blood goes into this LVAD device and it circulates the blood throughout the rest of the body. Now, some crazy things about this. That left ventricle, whenever it squeezes, circulates blood, that's what creates a pulse. So since there's no left ventricle in play, but it's simply a fan or a circulating pump of this LVAD that circulates blood, it does not pump it. So since there's no pumping mechanism, this patient will not have a pulse. The patient will be well alive looking at you, but you will not be able to feel a pulse. So with that, you can't feel a pulse, you can't assess a blood pressure, but you can auscultate over the heart and hear this device running. You can see that it's powered on. It'll have green lights, power switches. It's a pretty simple device. So there's a few things you have to do before you even begin CPR on these patients. One, you need to make sure that the LVAD is turned on, that it's doing its job. It just didn't somehow come unplugged, the battery die accidentally, whatever it may be. So ensure that the device is working properly. Auscultate over the heart to see if you do hear it running, making sure that it's getting its circulation effort going. Since you can't do the CAB, checking for pulses, everything else, you got to kind of troubleshoot it. And even some protocols will say to call the 1-800 troubleshooting number on this device before you call them, because this device is sewn into the heart. If you go and do CPR on them, it could essentially rip it off the heart. So CPR on these folks is a very last ditch effort. Even a lot of times with them, they may have a DNR in place because they go in, CPR has been performed, it may just completely break, disrupt everything, and chances of reviving them are very slim. Now, it's a very specialty thing. In our area, the only options for hospitals that can do anything at all with this is in Pittsburgh or Cleveland. So most generally, anytime there's a patient having an issue with one of these, they go to a hospital in Pennsylvania or Ohio via helicopter. That's even a lot of times a general medical patient, even if they're just having chest pains, that's where they're going to go because they need to get there quick. Other hospitals around here don't have any way to treat that. But big thing with them is just the assessments to make sure you're not doing CPR on someone with an LVAD just because you didn't feel pulse and they're actually have low blood sugar and they're just unresponsive. So good assessments, just knowing that these are out and about. For example, there used to only be about 6 of these about 5 years ago in the whole entire state. Now there's more than that in about every county.